Welcome to the Interventional Glaucoma podcast, brought to you by Elias. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field.
Hey everyone, this is Ike Ahmed from Toronto, Canada. Today, it's my pleasure to start another episode of Interventional Glaucoma, the podcast. This is a series of podcasts talking about various topics in the IGO world. And today, this is an interesting one, one that to me wasn't quite evident early on in my career in MIGS and interventional glaucoma, but yet has become an important part of employing and operationalizing MIGS and interventional glaucoma. The topic today is the importance of goal setting and setting expectations in glaucoma. And we're pleased to talk about a schema that was put together with the support of Elios and discuss and debate this. And with me, I have three wonderful friends from around the world. We have Nate Radcliffe from New York, always looking sharp. It's a podcast, but if you saw the video here, you see he's looking very clean and well-groomed today, which is unusual sometimes, but he is today. We have Tiziana De Francesco, who's from Brazil, who's always on top of things and looking great as well. And we have Mark Gallardo, who's, thank God it's a podcast, he's thinking, because he's not on video today. And he always addressing, well, he always bugs me about the fact that I'm wearing clothes from 20 years ago, and he's always in looking great and styling. But everyone's looking good today, and I'm happy to be here. Thank you all for being here as part of this podcast.
Happy to be here.
Thank you.
They're very excited, as you can hear, but really they look more excited than they're hearing right now, but you're going to hear it in their voices very soon. All right. So listen, let's get into this here. I'm happy to sort of lead the discussion and talk about it. So let me just start a bit here. We'd like to talk a bit again about goal setting. So tell me why you feel, or why you don't feel, maybe why goal setting is important in general in glaucoma treatment and management.
I can start with that. I think when we're talking about setting treatment goals, it's we're trying to explain we're trying to make patients understand where they are, like in the pre-op, and how they can be realistic, how they can achieve a realistic outcome in post-op. And I believe when we don't communicate well with patients, when we don't set the goals of the treatment, patients can be easily frustrated, can be easily be a source of patients' disappointment. So whether goal is reducing IOP, reducing medications, patients needs to be aware to understand how successful was the surgery.
Great. Yeah. I mean, I think that probably applies to everything in life almost, right? Like when you're, going out for dinner, and if you're like at a not so fancy place and your date thinks it's going to be fancy, that sets up for poor expectations. And same thing for patients. What do you think, Nate? I mean, you're a guy who always sets expectations. How important is it for expectations in glaucoma treatment?
Yeah, I think, one of the things as I think about our goals, I think about my goals and being realistic there as well. And I also think about choosing patients whose goals can be realistically achieved. So my favorite type of patient really to treat for so many of these new innovative glaucoma procedures is a patient with reasonably well controlled pressure, but tolerability issues, because, it's so likely you will be successful in terms of stopping a drop, helping their hyperemia, helping their, if they have an allergy and you choose some procedure to help them get off a drop. I love that concept. And it's also amazing that, a lot of the patients I treat where I'm satisfied, I wasn't shooting for a target goal. I was shooting for some quality of life goal, helping them with a specific problem. Also identifying the problem that they're complaining about before you offer the intervention helps them draw the connection between what you're offering and what they came in complaining about. And I like to make that connection really clear so the patient doesn't feel like I'm just throwing a procedure at them. I do think patients get thrown off if they feel like a procedure recommendation comes out of nowhere. So it's not just a patient goal, which I agree completely. We need to have clinical treatment goals. There's my expectations, and then there's connecting that as well as I can pre-op so the patient really feels like I'm listening to them and kind of addressing something that they have brought to me rather than throwing my procedure at them.
I like that, Nate. I mean, that's really important because I sometimes we think about goals are just what you tell a patient, perhaps, but it's also to remind us why we do what we do, which I think is a really good, anchor to kind of consider that. Mark, I feel like the old days, you're not that old, but the old days of glaucoma surgery was kind of simplistic. Like, your pressure's too high. We need to get your pressure really low. We're doing trabeculectomy. That was kind of surgery, right, for glaucoma. And it was like high risk, but you know what? We need to do it. And it was maybe somewhat, maybe I'm wrong, maybe it was a bit easier. But now we have, procedures like, phaco MIGS and, alternative blood procedures and things like that. I mean, has it made things more complicated in setting expectations? Like, for example, my patient's neighbor has surgery, they're off all their medications, and why am I still on the medication? And they have different procedures and things like that. It's kind of like the whole IOL story as well. What are your thoughts on how or how not, things have gotten complicated with goals and in managing different procedures, and how have you approached this?
It's almost like you read my mind, Ike, because I was thinking about how times have really changed. When we were doing our training and when we first got out of training, at least for the first 5.5, 7 years, when we were looking at goals for treatment, it was simply to preserve vision at any cost. And so when we were intervening on patients with surgical management, we understood that there was a chance that we might lose vision because of complications of the filtering procedures that we were doing. But at the end of the day, if we got the pressure down, even if we lost a little bit of vision, we achieved our goal, and we made patients believe that was completely acceptable because our goal was simply to preserve the optic nerve and get the pressure down. But nowadays, you're right, with all of the different procedures that we have and really patients' expectations. I think when we talk about our expectations for surgery and going into them, I think sometimes we have to temper patients' expectations because we live in an era where everybody wants something done. They want it now, and they want it without any kind of sacrifice on their own end. And so, patients are so used to being 2015 or 2020 after a surgery, they expect the same thing or the same kind of efficacy with glaucoma surgery, where if we're going to do something, they're going to want to ensure that when the surgery is done. And I think from my perspective, it's critical that we really inform patients about what we are expecting out of surgery so that they can understand what to expect, including the fact that procedures we do may not work. And it's not because we did something that was wrong in surgery, but it was really because the eye responded in a way that we weren't hoping for. And sometimes, again, in today's society, it's never my fault. It's always somebody else's fault. And so I think it's very, very important to temper patients' expectations and really get them to understand limitations of modern science and modern technology. Despite all the great advancements we have, we will have some failures, but there are some patients that just won't accept that there potentially might be a failure. Because if it's a failure, it's really the surgeon's fault for not doing the proper thing.
And how do you express that? I mean, obviously, just speaking in like IOPs and medication doesn't really capture that. But do any of you, present it in or probabilities or percentages, or how do you set that and make it clear that there's this percent per success, this percent is failure? I mean, how do you share that idea of not everything's 100%?
When I talk to patients, I really include the experience that I've had over time. Thankfully that we've had access and experience with angle-based surgery and minimally invasive blood procedures for close to a decade now. And I do let patients know what I typically see in most patients. However, there are a subset of patients that respond a little bit differently than what we expect. But going into surgery, we know there's a very high probability that they will have a successful procedure, and we'll be able to achieve those reductions in intraocular pressure or medication burden that we had sought to reduce. But just knowing that I feel the biggest risk of any of the procedures that we do is just failure over time. And so I really get them to understand that, yes, we have a lot of experience. We see a lot of patients that have had these procedures and they've done well for a very, very long time. But we have had a subset of patients where we do a procedure and it works for a few months. The pressure comes up, we intervene again, it works for a few months, and then it stops working again. And at times I send patients out of town to maybe get a second set of hands involved, and then the other practice does a few procedures and they fail over time. And it's really coming down to how their eye is responding to treatment, not necessarily how we're doing the procedure, but it's more about how the eye is responding.
That's great. Yeah, and I like to use percentages often. I will use some of our studies to kind of say 70% probability of success defined by, whatever parameter, reaching a target pressure with no more medications and not needing surgery within 5 years. I mean, just to give them a number, and then I give them a risk. I'd like to know 1% chance of a very serious complication, you could lose vision. And I personally feel documentation is important. I can't tell you how many times, patients are unsure, and I'm like, I just want to remind you that this is important. I think I even think giving them something is helpful. We're going to talk about that a bit as well. But Nate, I want to come to you just back to one point about this. How do you manage it when you find that patient expectations are so divergent from yours? I mean, how do you address that?
I was going to ask you this question, like, because, I know people fly from all over the world. You're the best. Sometimes I almost don't like it when a referring doctor says, like, Dr. Radcliffe's amazing. He can handle anything. And you're like, well, I can't. And, I'll try to let the patient know, I think I heard myself saying earlier today, I didn't invent glaucoma. I'm just here to tell you, what the rules of the game are. Because I was delivering bad news. You might need a second surgery. This might not work. And I'd change it if I could. I give them the numbers, like you were saying. Not everyone's great with numbers. We overestimate large risks. We underestimate small risks. I want them to kind of get the general concept that frustration is part of this game, at least when you're talking about major surgeries, but sometimes, less frequently, these, the newer MIGS. So, I really try to bring them back down. I will have people sometimes repeat after me, like if I feel like they're really not getting it. And I try to remind them they came to me because they're worried about going blind. I feel like if you don't kind of establish some of these things, there's like a bait and switch from the patient's side where they kind of try to turn it around. And, you have to be firm. And, as someone who's a people pleaser, I really don't want to deliver a lot of the bad news I have to. But, ultimately it helps the patient be more successful, meaning happier with their life after surgery. If you can kind of, deliver the news in a way that helps it hit home and give them understanding.
That's great. Well, listen, I want to move on to this tool that was developed, and I found it to be useful. And I'm gonna actually ask Tissy maybe to give a bit of background in terms of because you were involved in the development of this. Tell us a bit about the tool and how was it how did it evolve and what were the purposes of it?
I was happy to work with the development of this tool with my colleague Ike Ahmed and other colleagues. And we believe that setting a goal is an important step towards achieving a happy patient after phaco MIGS. And the goal with this tool is to make sure that we communicate better with our patients regarding expectations. So in this schema, we discuss 2 points. The first one is the impact that the surgery will have on the disease. So we will be discussing if the goal is reducing IOP, maintaining IOP, or if the goal is reducing, slowing the progression of the disease or reducing medication side effects. And the second point we're discussing with this tool is the impact that the surgery will have on glaucoma medications. Are we maintaining the medications? Are we reducing the medications? Or is our goal eliminating totally the medication? So I believe with this tool, we make sure that surgeons and patients, they're synced. They're in the same page when it comes to phaco MIGS outcomes. And so this is the goal of our tool, to better communicate with patients and make sure that our patients are well oriented before surgery.
Yeah, I really think that the group came together nicely producing this. I mean, it kind of helps to remind all of us, including our patients and ourselves and our referring doctors, why we're going to surgery.
It's common that we do a surgery in a patient that, for example, pressure is 14 and patient is on 2 medications. And we do surgery, pressure is the same, but we reduce medications and patients ask, oh, I did a glaucoma surgery, but actually my pressure is the same. but patient is not seeing from a different perspective that will reduce the number of medications. So that's why it's important to set the treatments goal before the surgery.
Yeah, and I think this tool is helpful. It's actually a physical paper you can use, and you can check mark it and give it to patients and document it in the chart. It's always good to reference back to it, because some of the things are not easy to measure. Like, how do we know, we're potentially slowing the rate of progression or reducing the need to go on to surgery? Well, studies have shown that even when pressures may be the same after surgery. So it just kind of reminds us on that. I know that there, some clinicians who started doing MIGS were maybe a little disappointed because patients are still on their medications, perhaps, or the pressure didn't drop as much as they were used to in trabeculectomy. So just a reminder of that, and I think a useful one at that in terms of why we do what we do. Nate and Mark, do you want to talk about, have you been able to use this tool? How did you introduce it to your patients? How did you implement it into practice, if you have?
So I haven't used the tool directly, but surprisingly, it's something that when I'm talking to patients, I've already been kind of using the tool in the sense that when I'm talking to my patients about where they are in their stage of glaucoma and their method of management, I do let them know why we're doing the procedure. So if I have a patient that's on a couple of medications, we're going into cataract surgery, I let them know that, listen, you're doing well on your medications, but I know long term the preservative in these bottles might end up damaging your natural outflow system. I want to come in and do procedure X or Y so that we can help your natural drainage system work a little more efficiently, so that we could potentially maintain your pressure but get you off of the medications. And it's pretty interesting when I talk to patients about eliminating or minimizing the medication burden. They're stoked. Like, they're really excited about minimizing their need for eye drops. But on the contrary, if I have somebody whose pressure is above target and they're on max therapy and I'm doing a MIGS procedure, I let them know that, listen, your pressure is too high. We're going to do this procedure because we really need to get your pressure down to reduce your risk of progression, and you might still need some medications to control it. And if we find that you still have a little bit of ocular toxicity from the drops, we can titrate and maybe do another little microinvasive procedure or laser treatment to try to minimize your burden even more. And so it's something that I've been doing over time. It's just a matter of educating patients and letting them know not only the risk and benefits of the procedure, but the purpose of doing the procedure and what the outcomes might be.
If I could just piggyback on this, I mean, I think that, there's a joke with traditional glaucoma surgery. There's so many ways to lose, because you can have all these complications. And, when you move over to the more minimally invasive procedures, this is a list of ways you can win. And, it's not uncommon to have that patient who's like, hey, wait, we did all that, but this, and I still have this problem. And this just gives you a lot of things to revisit with the patient. Like, for example, I love maintaining eye pressure. It's an amazing, if you're good in glaucoma and you can stay that way, that's amazing. Not everyone gets to, and I love slow the rate of progression, because we know that now from at least 2 studies that, having surgically or laser reduced eye pressure may be better quality than drops, and it may all look the same, but the patient's going to do better. And, when a patient's kind of pressing you a little bit, to have these goals or just even these talking points to revisit with them and sort of explain, help comfort them, help them appreciate how complex the disease is. I think it hits all the good points for me.
Sissy, have you had a chance to, or any examples where you've been able to use a tool like this, or where it's helped you?
Yeah, I have a few cases, actually, a few interesting cases that I have to share. But one that was that I recently used was a patient. I did a phaco MIGS on a patient that had mild glaucoma. IOP was a mid-20s. Patient was on 3 medications. And the goal of the surgery since the beginning was IOP reduction, not medication reduction. And I had this conversation with patient in the pre-op. And after surgery, pressure was on target. Patient was still on 3 medications, and I had a happy patient. My patient was not frustrated because was still on the same medications. So patient, in this case, he preferred to avoid a more invasive glaucoma surgery and keep the medications, but achieving the target IOP with the same medications. And we were fine. We had a good conversation, and patient was happy with the result.
Well, thanks everybody for sharing your perspectives on goal setting and expectations. I know we all generally agree with the concept and also the differentiation between what we set for goals for example, MIGS surgeries versus BLEB surgeries. I feel that I'm a big documentation fan personally. We probably over document sometimes, but when we need it, we appreciate having it, whether it's a patient or a referring doctor or even a lawyer, to be honest. I think if we have something documented, it always is a reference point to look at and to remind us what our goal is, and to reference back to it, so we can have a landmark to go by with. So this is a tool. I hope people get a chance to use it. It's pretty straightforward, and something that we can give to patients for them to take home and remind, and also for us as well, and us to incorporate it into our notes and into our correspondence with our co-managing doctors. So we thank you so much. So I appreciate you guys all being here.
Thank you so much for the invitation. It was great.
It's always fun.
Thanks
all
for
right.
having me.
Thank you as well for tuning into the episode of Interventional Glaucoma, the podcast. And I hope you'll all enjoy these episodes, and there's much more to come. Thank you to Ilios for sponsoring this, and we'll see you again on another podcast. Sayonara. Take care. Signing off. Bye.
Find out more about this schema at the link in our show notes. Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision is a wholly owned subsidiary of Bausch & Lomb. Elios Vision GmbH is the EU distributor of Elios, manufactured by MLaser GmbH, and the Fido laser applicator, manufactured by Vinert Fiber Optics GmbH. Elios is CE marked and licensed for use in the EU, and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.